What makes you the facelift guy?
They can do them like us, but they can never do them just like us. I don't know that it makes a huge difference. I think you can start a fight on that one. Affecting future facelifts is going to be one of the biggest challenges that we face in the next 10 years.
Super excited to be here today in St. Louis with my good friend, Dr. Mike Nayak, the Facelift Guy. Learn a little bit more about what makes him tick and how he became the Facelift Guy. Mike, good to see you.
Good to see you, Steve.
Thanks for doing this.
A lot of fun.
Yeah.
A lot of fun.
So I came down here because I wanted to chat with you because I had a patient in my office recently and she was talking about, like, do you do facelifts like Dr. Nayak? I'm like, well, I'm not sure. So I had to look it up, see if I do them like you, and I don't know if anyone does them like you.
I would say there are lots of people that do them like me.
Yeah.
I think in the same way there's lots of people that are great chefs or great and they're in the same school. But the wonderful thing about our field is it's very artistic, it's very artisanal, it's very individual, and I think that's what will keep us interested in it forever. And so they can do them like us, but they can never do them just like us. And it's not because of a skill or a training thing. It's just because of a personal flair kind of thing.
All right, so I want to, for those people who don't know you, and I think everyone does, but for the few that don't know you, you graduated from Yale, summa cum laude. Then you went to WashU, which actually I went there also, but you went there for med school. Then you went to Mass Eye and Ear at Harvard for a residency, and then you did a fellowship with the Glasgolds.
That's true.
Why did you go into otolaryngology? Like, what was the reasoning for that?
That's a great question. So in medical school, I was torn between internal medicine and otolaryngology.
That's unusual.
I know. Well, internal medicine had the puzzles and the fixing things and the cerebral part of it. And when you're in a tertiary referral center, you get all the zebras and all the crazy stuff, and it's and you're in that stage of your medical career where those things are really fascinating. And I didn't know that the average internist, 90% of what they do is general health and the same cluster of 5 conditions, and it's more, you don't get as much of the fascinating, you get some, but you don't get as much of the fascinating Dr. House stuff that you see at the tertiary referral center. I also liked otolaryngology, and I liked it when I was a first year medical student. We had a little clinical hour every week that was run by the chief medicine resident. And towards the end of that semester, she went around and said to each of her 5 charges, you're going to do this when you grow up. And she looked at me and she goes, you're going to do something really technical that works with your hands, like otolaryngology. And she was right. But anyway, I like otolaryngology because it's got a lot of the medical otolaryngology stuff is also very cerebral. But then it does have the technical manual aspect to it. And so what ended up swaying me that way was kind of realizing that the 90% bulk of the day in otolaryngology was going to be more rewarding to me than the 90% bulk of the day in internal medicine. Maybe the 10% might have been a little more puzzle mastery in internal medicine, but I had to go on and now looking back, thank goodness I made that decision because I feel like I ended up where I should.
So why cosmetic medicine or plastic surgery?
It's the same kind of thing. I don't know how your evolution was, but I went into otolaryngology with the love of the whole field.
Right.
And then, I don't know, 2 years in, I realized I liked the soft tissue surgery more than the functional surgery. And to me, that's what we do. We do soft tissue surgery. And it has allowed me to marry soft tissue surgery with some self-expression, with a little bit of business management and all these things together. And I think it's a lot of it was just luck. And sometimes you wonder, if I had done something else, would I have been happier? And I don't think so. I think I really landed right where I was meant to be.
Are there any benefits to the route you took through otolaryngology that you think help you today when you're in the operating room?
Yeah, so I do exclusively facial plastic surgery. So I think if I was someone that was doing, off-face surgery or breast body surgery or something like that, I think, I would have absolutely. I mean, if I was wanting to do full scope plastics, I still would have done otolaryngology to begin with, and then a plastics fellowship afterwards, because I feel like the soft tissue training, the head and neck expertise and comfort is fantastic with otolaryngology training. You can't get much better with comfort in the head and neck than otolaryngology training. And since breast and body wasn't my love, to go from there to facial plastic surgery, For me, that was perfect. I will say politically, knowing what I know now, if I was looking, and I'm not a political animal, but if I was looking to be kind of a political mover, shaker, that kind of thing, I probably would have done plastic surgery and a facial plastic fellowship, just in full disclosure.
Yeah.
In the operating room, I feel like I'm in a stronger position. Now it doesn't matter. 20 years in your career, nothing matters what your training was, really.
Right.
But I feel like when you first get out of training, you're in a stronger position for nasal surgery and invasive face neck surgery, like real deep face neck surgery with an otolaryngology background than with a plastics background.
When you did you go off on your own immediately, or did you join someone at first when you started?
I actually joined one of my old attendings for the Mass Eye and Ear, Mark Farveris, one of the guys that really shaped my career. He had come back to St. Louis University, which is where he started he did his residency there and then finished at the Eye and Ear. Started as attending here, finished at the Eye and Ear, and then he came back to take the chairmanship here at SLU, and I joined his department here at
St. Louis University.
St. Louis University for 2 years. And about a year and a half in, it was clear that I wasn't going to be able to develop as a surgeon if I stayed in that place.
What do you mean? What do you mean you went to develop it as a surgeon?
Not because he was a fantastic supporter. It's hard in a university environment. If I wanted to work past 5 p.m. to be able to attract working professionals, I couldn't get staff coverage. If I wanted to work a Saturday morning to attract working professionals, I had no unique selling propositions, right? The only thing I had was availability. So I could be available when an employed person might want to see me and not take time off of work. I couldn't get a receptionist. I couldn't get a medical assistant. I couldn't get block time. So if I could get one of these people to commit to have surgery with me 3 months from now, I couldn't give them a guaranteed operating date. And lots of frustrations like that. I didn't have control over who my staff members were, kind of what service level we provided. And lots of those frustrations made it clear that I was never going to develop the kind of career I wanted to if I didn't have the ability to make myself appealing to patients in ways that you have to when you're first starting out, and then also be time to deliver the care. Surgical block time is important.
So how many years were you at the university before you went off on your own?
I was there for a total of 2 years.
2 years, that's pretty quick.
Yeah. Well, I knew about a year and a half in. So again, Mark was a great friend, and he was the chairman still at that point. And I told him that it was going to have to.
Are you entrepreneurial?
A little bit, yeah. Not like you.
No. Well, I mean, entrepreneurial, I don't think it necessarily means like money focused. It might mean trying to create new things, and I think it's a creative endeavor to be entrepreneurial, in my opinion. I think there's a lot of entrepreneurs who struggle financially, to be honest with you, because they're too entrepreneurial.
Yeah.
And I think that can be an issue. So you go off on your own, then you start your practice. And how many years ago was that?
That was 20 years now.
20 years.
Oh, no, sorry. I take it back. It's 18 years now. It was 20 years since I entered finished fellowship, so it's 18 years ago.
18 years.
Yeah.
Yeah, I'm a little bit ahead of you. I'm about 21 years now into it. I remember when I first went into practice, I went in with Gene Tardy, and you remember Gene Tardy, right? And he was a big name back in the day. Now it's like my fellows and residents are like, who? Which always amazes me that you think you're never as big as you think you are, and your name never lasts that long. One generation later, no one knows who you are anymore. My residents and fellows barely know who he is now. But back in the day, he was one of the biggest guys in our field, and he taught everyone, and if you wanted to get a rhinoplasty, that was the guy to go to in Chicago. I remember my first facelift. I went to him, and I was so nervous. I'm like, Dr. Tardy, I'm so nervous. I couldn't sleep last night. I'm doing my first facelift. I said, when did you stop getting nervous? And he said, I never did. And he goes, that's why I chose you, because I knew you would never stop being nervous.
Yeah. They say you go from challenges and complications, you go from being terrified about them to later in your career, they're kind of interesting. I'm still not that kind of interesting state. I'm not terrified anymore.
Right.
I'm able to handle them. I'm a big boy now. But they're still not, oh, what a fun quirk, what a fun challenge for the day. They have not hit that stage. They said that would happen one day. It's still not there. So
you're being known as the facelift guy now, which is interesting because you also do rhinoplasty and blepharoplasty and you do everything, but you're really known for your facelifts because your results are so fantastic. And I think anyone who in our field knows your results are great. They see you teach. You are all around the world teaching now your techniques. What makes you the facelift guy?
This is a new thing to me because I agree. I do still love and do rhinoplasty, blepharoplasty, brow lifts, all those kinds of things. And I don't really know how that happened. I think a lot of that is an online phenomenon. You know, online is an echo chamber for everything, including titles and that kind of stuff. So I love it. I mean, I if I'm going to be known as something, I'll take Facelift Guy. Like, that's great.
You love what? Surgery or facelifts?
I love facelifts.
Okay.
But what I was saying is I love the title. If you're going to saddle me with any title, that's a great one. I'll take it.
And that was in Elle magazine. They called you the Facelift Guy.
Yeah.
Okay.
Yeah. So I will say, I think the number of people. This is really interesting. I think a hard rhinoplasty, in my opinion, is a lot harder than a hard facelift.
I agree.
Rhinoplasty is a much more challenging operation.
You don't know what you're going to get. You go into that nose, and you get 3 hours later, you can be like, I can't believe I got to like start over again.
Yeah. So rhinoplasty is a much more challenging operation. But interestingly, I feel like there are more people in this world that can do an excellent rhinoplasty than can do an excellent facelift.
Why?
I think part of it's cultural. When I say in this world, I mean in the world, not the U.S. world, the world. I think part of it's cultural. I feel like the U.S. is a little ahead of the curve on aging face, whereas South America and Europe and Asia are maybe behind on aging face, where they've all been pushing the envelope in rhinoplasty for 20 years. You know, and so I think the access to good training in rhinoplasty is broader right now. This is changing. And I think just the population of surgeons that are doing rhinoplasty is bigger right now. As far as how I got to be known as the Facelift Guy, I think a lot of it, again, is just result driven or echo chambery kind of stuff. I love the moniker, and I intend to keep it as long as I can. But it's not like I just set out one day and be like, I'm going to be the Facelift Guy.
So what did you set out to be?
This is really funny. So when I first came to town, I remember very clearly, I remember a lot of decisions I've made in my life that I look back now and laugh. So one of them was when I was in medical school. It was 1993. I remember very clearly that I was just not going to use email. I mean, because, you know, we have voicemail. I don't need email. I remember making that decision. I'm never going to use email.
That didn't last very long, did it?
Similarly, I remember when I came to town here, I was going to be, the simple country facial plastic surgeon. I was very nervous, again, about the kind of political, interdisciplinary tension kind of stuff. I was going to fly under the radar, and if no one ever knew my name, I was going to be totally, I was like fine with that. It was a decision I had made. I'm going to be a local facial plastic surgery provider.
That didn't last either.
That didn't last either, but I remember it was the same kind of decision as the email thing. It's like, this is what it's going to be. So, yeah, that's.
So you didn't set out to be the Facelift Guy. You set out to be a country local plastic surgeon or facial plastic surgeon and do stuff for the community. How did it evolve, like to where you are now? Did you, like the glass gold, you did facelifts and rhinoplasty, of course. The deep plane facelifts, so you went in that direction. There's so many different types of facelifts today. And I remember coming through, do we do subperiosteal? Do we do a SMAS? Do we do an extended SMAS? And then deep plane became very popular. And you really took that mantle and seemed to have driven that forward and extended it to the deep neck. How did that occurrence happen?
So it's a great question. So the one thing I want to state, and I state this as often as I can, almost nothing I do is my own, right? Almost nothing I do is something I came up with.
I love that you say that you give credit to those people, right?
Oh, I'm about to piece by piece tell you where the different pieces come from. So I think the thing that I happen to be good at is I am very fortunate to have known or met or become friends with the people that I consider to be the best in the world at various sub-focuses within aging face surgery and rhinoplasty, actually. So I really feel like the people that I consider to be the best in the world and all the things that I do, I know well, have had discussions with them, have seen them operate or whatever. And so I think my greatest blessing that I've had has been my knowing these other docs and being able to take knowledge from them. So when I did my fellowship with Mark, he was doing deep plane facelifts, not to the extent that we are now, but a true deep plane, at least in the lower face. And this was in 2003 to 2004. So Mark Glassgold was the first person to introduce me to deep plane facelifting, and that was during my fellowship. When I came out of fellowship, I immediately went to just mass application or purse string mass application facelifts, because even just raising a skin flap was a challenge, right? Or doing an appropriate basic facelift was the level that I should have been at that stage. And so that's what I did. And I did that for a few years until I got my surgical chops, solo surgical chops, kind of comfortable. And then I went back and did deep plane facelifting, what I'd call traditional deep plane facelifting back at that time. Around that time, I was on staff here at St. Louis University. They had a oculoplastics course running at their cadaver lab every year. And I said, hey, you want to do a facelift course? And they said, sure. And so in 2004, I started their facelift course. We've been doing it for 21 years now. And I invited all the people that I had no business inviting. This was back in the day where you couldn't just Instagram somebody, or you had to write them a letter, and I wrote letters to all these people, Oscar Ramirez and Tim Martin and Bill Little, and people that
well-known surgeons, plastic surgeons,
people that would have no reason to respond to me. Sure enough, most of them did. And it's one of the ways that I got to know some of these guys. Tim Martin came in to help me teach the facelift course around 2006.
Wow.
And I was 2 years out of fellowship. And he is the guy that I credit as often as I can with teaching this head and neck surgeon kind of the reality of the shaping of the deep neck.
Yes.
And so he credits Bruce Cannell as loudly as he can, right? And so, although I'm a head and neck surgeon, although I was deep plane facelift trained, I didn't understand the deep neck until I really got to know Tim. And so Tim is my
so for the people who don't really know what this means, I just want to, can you give a brief explanation of when you say deep plane facelifts or deep neck, what do you mean by that? And then also, can you tell me really quickly what the advantages of those over the traditional methods?
Yeah, so let's start with the deep neck. The neck is built in layers, like your belly would be built in layers. Skin, fat immediately underneath that, a muscle sheath like your abs here. Here it's the platysma, and then behind that are your organs, right? And so just like through the belly, you could make a certain amount of shape change by liposuction, just thinning the fat between the skin and the muscle. You could make perhaps some more between thinning that fat and taking a little bit of overlying skin away. You could perhaps make some more change by also tightening the muscle sheath. But if it's a pregnant woman, you can do all those things and the belly's not going to change shape very much, right? If you deliver the baby, suddenly the belly really changes shape. You're changing what's behind that muscle structure. So the same thing in the neck. There's the skin, there's fat you could theoretically suction some of, there's the platysmal layer, which is low layer muscle, but the baby, the bulk, all the real structure is behind that muscle layer. And so with deep neck lifting, what we're doing is going immediately to the deep layer and sculpting fibrous tissue, fat, glands, muscle, things that really set the foundation, the bedrock shape of the neck. And then having the superficial layers as passively as possible follow those shapes so it looks soft and pretty, but the shape change is powerful. Again, it's like delivering the full-term baby, not leaving the baby in there and trying to liposuction a thin layer of fat over the tense.
It's a great analogy. And then you're not getting the tightening effect that people are saying when they're getting those sweeps, because you're taking out the materials below the skin and it's just falling out.
And having things passively draped. Similar on the deep plane facelift, not exactly, but the deep plane facelift there are 4 or 5 layers in the face, and some of them are, most of us believe, more natural to travel within. If you can travel within those layers, free them up adequately and move them, you get a passive, beautiful redrape of the face. The problem is those layers are a little bit hairy. They have all the nerves near them and the blood vessels and those kinds of things. So at the deep plane facelift, you have to be skilled enough to travel near those nerves and blood vessels and not injure them. Get that layer fully freed, but the payback for that is you get to passively reposition the entire bulk of the face back where it started without that strain.
So is the risk higher doing a deep plane facelift versus a traditional facelift of a permanent injury?
I think the risk is, it's kind of like the risk of driving a race car at 200 miles an hour versus driving a car in the parking lot at night at 15 miles an hour. It depends on who's driving. So if you have a race car driving at 200 miles an hour, you can have a pack of them going around the course, and by the end of the race, chances are no one's going to get in a wreck.
Okay, so skill set here makes a big difference. Experience makes a big difference. When did you start to get to a point where you're like, I think I got this down. I think I understand this. I feel comfortable in the deep planes.
So it's incremental, right? So like I said, I was trained in deep plane facelift and intentionally did not start doing deep plane facelift when I first got out. Because the last thing you want to do when you have no reputation, you have no I should say self-esteem. You don't have the confidence to handle complication yourself yet. Is to face something like that. So I waited a couple years. I did basic, easier facelifts. The things, we're talking about the 15 miles an hour in the parking lot. If you have a 15-year-old permit driver, they should be driving in the parking lot at 15 miles an hour. They shouldn't be on the racetrack. Right? As that 15-year-old permit driver becomes an experienced professional driver, get him out on the racetrack. So I did a few years, probably 2 years of just basic. It made people very happy. I built a reputation locally of generating pretty results, because a lot of pretty is not about technique, it's about vision, right? So you can generate pretty results with multiple techniques. So I generated pretty results safely. I developed confidence. I developed a good reputation. I developed more soft tissue skills, where now you can take another step and another step, and you're driving at 40 miles. You don't go right to 200, you're driving at 100
And I've
miles.
heard you teach, and I've heard you tell people, stop when you're uncomfortable.
Yeah, absolutely.
You don't have to go deeper just to prove something.
Yeah, absolutely. And again, you don't have to take every step to the nth degree. So I feel a little bit sorry for some current, brand new surgeons, brand new injectors. When we first got out, injections were lips and nasolabial holds. Now, if you are starting injections, you immediately are expected to do tear troughs and temples and cheeks and jawline. Same thing with facelifting. You get out, and if you say to someone, I'm going to raise a few centimeters skin flap and tighten some tissues and close it back, it sounds like, what are you even doing? So it's
all right. So
that's appropriate for certain levels.
I agree with you, but the question I want to get to is, are you at your peak right now? Like, have you peaked as a surgeon? Are you at your best, or is there still room to go?
That's a great question. I'm going to give you the two answers. The true answers, I think, probably. I think this is one of these bigger, human arc kinds of questions, right?
Yep.
And I think the reality is there's a window in a surgeon's career. I've actually done a post on this in the past, where I feel like you've gathered enough experience, and you've learned enough. You've filled your toolbox. You've filled your emergency toolkit to a point where, it's probably getting a little more full over time, but not much more full over time. But at the same time, your spine's starting to give, your hands are starting to give, your eyes are starting to give, your stamina, your mental ability. And I think there is a window, and I want to selfishly say it's from 52 to 60. But I think it's kind of 50s.
So I agree with you on this, because it's a lot, right? You're physical, because after a while it starts to get painful. I used to do 3 surgeries. I can't do 3 surgeries in a day anymore because I'm too wiped out. So I'll do 2 surgeries. So physically you take a step back a little bit too. But I also think as you get older and you do more of these, you get pattern recognition. Like you're like, oh, I've been here, and you know how to work through it really quickly.
Yes.
Whereas when you're younger, you're like, wait, what am I doing here? Am I in the right plane? I've never seen this before. And there's so much value to that. And I always think of Michael Jordan, because I'm a Chicago Bulls fan, of course. When he first came to the league, he was like doing these huge dunks over everyone, and no one could catch him. And then as he got older, he sat back, he saw the whole field, he saw the whole court. He would got these great jump shots. And I think the surgeon's kind of the same way. You find that area where you become at your best. But let's not fool ourselves. There comes a point where it's like, okay, you're not as strong as you used to be.
Yeah. So I think 50s are kind of the peak of a. So I mean, if you're not getting better as you if you're not learning more as you advance, then you shouldn't be doing it, right? But I do think there's kind of an intersection between the senescence on one end and pattern recognition experience on the other end, and where that intersection is, where the plateau of those two curves are, I think is 50s. Truthfully.
Tell me how you got into teaching and why you love teaching so much.
So I mentioned earlier within medicine, it was going to be either internal medicine or ENT or Oology. Career-wise, it would have been teacher or doctor. Those would have been the two.
It's so funny. I would say the same thing as well.
Yeah. Well, you're built the same way.
Yeah.
So that would have been the bifurcation for me. So teaching is just something I enjoy. I almost can't help it. It's kind of built in. And It's interesting. I was in academic practice for 2 years, but I teach now more than I ever have.
Yeah.
And it's just nonstop.
Because you have people come from all around the world to spend time with you. In fact, I wanted to book a day to spend time with you in your operating room, and you're booked out a year with observers from all around the world to come to learn.
It's to me, this is all crazy. This whole thing is like crazy to me. I'm just telling you for real. So I have 3 people a day every day. I operate 4 to 5 days a week, and every one of those days I have 3 people per day watching surgery.
Do you charge them to come to you?
No, they don't get to do anything. They don't get to touch anything. They just get to watch. But 3 people per day every day.
And how do you decide who comes to visit you? Do you credential them? Do you say you have to have a certain degree?
So no. So they have to be a practicing surgeon in an appropriate field. So, and by appropriate field, this is going to be controversial. Otolaryngology, oral maxillofacial surgery, if they're doing the right things, to me, it's appropriate field. Facial plastic surgery, ophthalmology, an actual surgeon that's modifying soft tissues of the face. And so, but I do that. 3 people a day every day in my operating room, and it's always hard to tell people no because they're like, well, how about just one more? And it's
right.
The patient has to come first, and at some point you are so busy trying to explain. There's 3 people asking questions, and they're talking to each other, and it takes away from the patient. So
I had an issue with this
6.
a few years ago. So where the patients started complaining, you're teaching too much, and I'm not coming to your office anymore. I was like, really? It was like a wake-up call to me. So now I restrict it also.
So you have to have a hard line, which is hard then when a friend says, hey, can I come all top of it? These guys have waited a year. So it's hard. So I teach, I have 3 people a day every day. I am at meetings probably 14 or 15 weeks a year, teaching somewhere.
And you're doing live surgery too some places, aren't you?
Yeah, so these meetings are typically lecture, cadaver lab, live surgery, 1 to 3 of those components, lecture, cadaver lab, live surgery. So live surgery in an outside environment is challenging. I actually take my own team, my own instruments when we do it, usually at my own expense when we do it.
And do you enjoy doing those live courses?
I do. They're I think also you're talking about career arcs. I'm probably not going to do that in my 60s.
Yeah.
For 2 reasons. One, there'll be some other young in their 50s hotshot.
Right.
But then 2, it is definitely more stressful to do those kinds of things outside home in a different environment. It helps to bring your team and your equipment and everything, but it's definitely different than doing it at home.
Isn't it interesting how the world's become so international with teaching and training? And I was looking at your schedule last year. You were, I think, in every continent of the world almost except Antarctica teaching, and you're working with other really well-known surgeons for facelifts. Do you come back from those meetings a better surgeon?
Oh yeah. So here's the best part. Every day we're talking about these. I have 3 observers a day every day. I learn something in my own office every day.
Yeah.
It's like visiting professors. They'll see me struggle with something, and they're like, "Hey, we do this." I'm like, "Oh my God, thank you for coming." So I have, I learn at the meetings, but I learn at home.
Yeah.
Teaching so between lecturing and visiting docs, and just online now. It's incredible what the exchanges are in chat groups and just direct messages and online video. There is no shortage of ways to learn. I said I feel sorry for surgeons these coming in.
Yeah.
They're also in the best place ever. Like if you have 10 minutes and an interest, you can learn something new. Make yourself a better surgeon right now.
Yeah, it's a lot easier today than it was when we were going through back in the day.
For sure.
And your relationship with patients, how has that changed over your 20 years in practice? Is it getting harder for you to have a doctor-patient relationship because you have so much else going on in your world? Or is it better now that you maybe have more support?
I feel like that has actually improved. There's a couple things that have improved it. One is I think if you're not careful, it could erode, right? But we all realize why we're here and who we're here for, and it's the patients, and that's really what your real responsibility is to your patients. Mm-hmm. There's a responsibility to pay it forward to other surgeons because you can never repay the people that taught you, right? So you pay that forward. But we're all here for the patients, right? And so that has to be really protected. And so we really do try to protect that. But second, as you intimated, having a great staff gives you better patient care abilities because you can focus more on the personal connection with the patients and really hearing them and really understanding what they're talking to because you're not going over so much how many pills to take, how many times a day, and all the real nitty-gritty details that you can have help with. Having a great staff gives you better patient care, because the patients will sometimes, I'm sure you've seen this, feel much more comfortable saying something to your staff that they don't want to offend you with. You know, they like you so much, they're afraid to tell you something. They're not afraid of you, they're afraid to hurt you. And so they'll confide something in a staff member that, thank God they did, because otherwise we wouldn't know about it. And so the great staff part is helpful in that way as well.
And you're attracting now a lot of people from all around the world, and I'm assuming some celebrities also. How is that different for you when you bring in these VIP patients?
So domestically, I would say 85% of my patients now are domestic travelers.
When you say domestic, what do you mean?
Within the U.S.
Within the U.S. Okay.
Yeah, not Missouri, Kansas area, not Missouri, Illinois area. So 85% of my patients come in from not a 4 or 5 hour drive, like outside within the U.S. Another 14% come in from this area, local, within a 4 or 5 hour car ride, and only 1% are international. I don't want to say, I mean, just to be in the interest of full honesty, I don't have like this group of airplanes coming in from.
So you don't have the sheiks coming in on the private planes like everyone else advertises, or the big facelift people?
Nope. So I have 85%. My demographic tends to be people that are looking for. There's a handful of really excellent facelift surgeons in the States, right?
Yes.
There's a group of us, and you know, spoiler alert, we're all friends. We love to see each other succeed, and there's only certain people. You can only get supported by people in your same evenly yoked kind of situation. So
how many is a handful?
I'd say 5 or 6, like really good, really like truly good, really good facelift surgeons. Most of them are bi-coastal. They're, you know, in the Northeast or in California. And so so a lot of the California patients end up going to one of the 2 or 3 excellent California docs. A lot of the Northeast patients end up going to the 2 or 3 Mid-Atlantic Northeast kind of docs. And so I tend to get perfectly wonderful patients that live around, you know, the middle part of the country. And
how much differentiation is between these handful of best facelift surgeons in the country? Like, are they going to get something different in California and New York than they're going to get from you in the Midwest?
I don't think so. I think they'll get very similar skill sets, but you'll get different surgeon personalities, and you'll get different stylistic outcomes. And so that's, you know, it's like picking, again, music. You know, there are a couple really, really gifted pianists, but you know, the personal styles are different. And I think that's what really attracts patients now is once you hit a certain caliber, now it's just what do you think is pretty and who do you think you're going to get along with.
You know, I get that sometimes with rhinoplasty. I've done thousands and thousands of rhinoplasty. I've done quite a few facelifts, but nowhere near the amount that I've done with rhinoplasty. And sometimes I'll say to a patient, I hope you go to me, but if you don't, this is the other 2 or 3 I think you should see, because the last thing I want them to do is go to someone who's not really an expert and for them to get into trouble.
Yeah, absolutely.
So there's a topic I want to touch on, which has come up recently. I got a survey from the American Academy of Facial Plastics on fillers and how that affects facelifts. And we've had patients come in asking about, like, how do non-surgical treatments affect your surgical techniques and results. Now, you did a post, I didn't see it, but a little while ago, talking about non-surgical treatments and surgery and how that affects you. What are your thoughts on that?
I think non-surgical treatments affecting future facelifts is going to be one of the biggest challenges that we face in the next 10 years.
Interesting.
Facelift surgeons, yeah, oh, for sure. So there have been, historically, most of the non-surgical treatments that you might do to a face are non-effective or minimally effective, and they didn't last very long. And
historically, non-surgical treatments are not effective.
Right. You know,
what do you mean?
Think of you know, devices from the early 2000s,
yes,
late 90s that were supposed lights, right? So yellow LED or yellow laser,
Zerona, whatever it was called, yeah,
right? Red light laser. They're not doing anything, but they're also not hurting anything, right? And so that was great. Or, you know, collagen, which was gone in 3 months, and we were only injecting lips and nasolabial folds.
Right.
You know, or Hyloform, which was gone in 3 months, or and similarly, only injecting very focal areas of the face.
Yeah.
Now we have technologies that really, truly change tissue. And so you're operating through changed tissue. You're not operating through natural tissue. We have injectables that intentionally or unintentionally create tissue responses around them. Sometimes because that's the desired effect, sometimes because that's a undesirable effect around a capsule formation or induration around even an HA filler. Then you have the fillers themselves, whether it's a granular calcium hydroxyapatite product or whether it's a fibrous kind of PLLA with collagen deposition around it, or whether it's a hygroscopic HA filler. The fillers themselves are in the tissues and are going to react. You have to dissect through them and they have to react to the surgery. And so I think our greatest challenge in the next 10 years is going to be not just the normal facial surgery is hard business, but also the tissues won't necessarily react the way they have for the last 10,000 years.
How often do you see filler when you go into a face?
I would say 90% of the faces that I operate on have filler in them. But how often do I see it right now? It's probably 30% of cases that I come across filler. It's usually in cheeks these days that you come across
And
filler.
what do you do?
If it's for eyelid surgery or rhinoplasty or chin implant surgery, we try to get it fully reversed before they're
You dissolve it beforehand with one of the reversal agents, especially if it's an HA.
Filler.
Right.
Yeah. If it's for face neck lift surgery, I don't currently try to have all their cheek filler dissolved or their jawline filler dissolved. I do know people that advocate for that because they feel like it makes their results more predictable with less swelling. It's hard to do in a travel-in practice. It's hard, and people are coming in, they want to spend 10 days and no more in St. Louis to do 2 or 3 or 4 rounds of reversal beforehand. So if they can have it done locally, most local injectors don't want to spend thousands of dollars on hyaluronidase to fully reverse someone's face before they come away for their facelift. So I have to work through it most of the time because it's just not practical to ask people to come in with no filler in their face, because it's a challenge to dissolve everyone's facial filler 100%.
Do you think your results are not as good because the person's had filler in the face beforehand?
I think when someone's had fillers or energy-based devices in their face, it takes the bell curve of results and shifts it. So I think it makes the average result a little bit worse. It doesn't mean you can't get the best result in some of those patients, but it makes the average result slightly worse because dissection is harder and tissues don't react exactly the way they're supposed to.
But you're in a deep plane, and most of these fillers are usually a little bit more superficial than you're at, aren't they?
Yeah, so I get that a lot. The answer is, one, fillers are not necessarily only put in one plane, right? So people think they're putting them in one plane. That doesn't mean that they are definitely there or remain there. And then 2, a deep plane facelift is in the subcutaneous plane for the first couple centimeters. And after you pass the midpoint of the face or so, even the deep plane is technically in the subcutaneous plane again, in the front half of the face. So even if you could say, well, these fillers are nowhere but the subcutaneous plane, once you get past about the apex of the cheek and enter the front part of the face, you're back in the subcutaneous plane, even in a deep plane facelift. It's actually the most challenging part of the deep plane facelift is forward over the zygomaticus major into the midface. That's deep plane, but it's exactly where the fillers are put, is in that spot.
So energy-based devices also, like I've done facelifts with energy-based devices, and the planes are harder to lift, in my opinion. Do you think this is where experience really matters?
Absolutely. It matters in a bunch of ways. So the analogy I use for these guys, it's like having a cold cheese sandwich versus a cheese sandwich that's been microwaved and then let cool again.
Yeah.
So, the cheese sandwich it's always slice of bread, slice of cheese, slice of bread. Anyone can take that apart, put it back together, and there's really no challenge to it. If it's been microwaved and put back in the fridge, it becomes very hard to get those layers apart without wrecking the bread on one side or the other. Right.
And the risk for complication, do you think, goes higher?
Absolutely.
Hematomas or bleeding after surgery?
So I think that's where experience counts, and that you can get through more of that challenge with experience, and you can also make the call, I'm not taking this any further. You can push that envelope a little more completely But I think you also start to notice, okay, this tissue doesn't look healthy. This tissue, I don't believe this is going to sustain what I need it to do. And so part of the experience can also be, all right, I'm not going to take this further than I've already taken it.
Right.
Knowing when to call it.
And so fillers and neurotoxins and energy-based devices are far bigger than plastic surgery. There's many more people doing that all around the world. Do you see this as a trend that's going to go away? Do you see it as a trend that's going to grow?
No, it's definitely a trend that's going to grow. So again, I'm so fortunate to have, usually 3 people per day from around the world in my operating room. They're way ahead of us on that. The rest of the world is leaps and bounds ahead of us in terms of the stuff they've been injecting into faces, the varieties, the materials, the pushing envelopes, the devices. They have been injuring the soft tissues of the face. And I don't mean that in a pejorative way. This is just, we do surgery, we injure the soft tissues of the face. They've been non-surgically modifying the soft tissues of the face a lot more than we have. And so they've been dealing with these challenges. South America, Middle East, Europe has been dealing with these challenges a lot in the last 5 years. And we can see that coming our way.
But they have a lot of fillers that are adulterated or that are permanent in nature. And I've pulled out so many fillers out of those faces. Not all those are approved in the U.S. In fact, few of them are approved in the U.S. Those really bad ones. And silicone, not many people are doing that at all.
Yeah.
And
so most of the HAs are pretty good. The issue is though the U.S. filler market, as you know, is drifting more towards the semi-permanent biostimulator world, even in the U.S. market. So, one, the HAs themselves are not without issues. They're more readily reversed, which is true. But I'm sure you've seen plenty of lingering edema, malar edema, weird under eye edema.
So edema, swelling in this area, which is really hard to treat after someone's had multiple treatment.
So
non-surgical.
They're not, and they're not. Even though they're reversible, doesn't mean that their effects can be reversed. Lymphatic obstruction that sometimes happens after these fillers. And then our filler market will evolve. It's evolving now and will continue to evolve. Most of the companies are putting a lot of effort into the stimulatory filler category, which will not be reversible.
Like PLLA and calcium hydroxyapatite in particular.
Yes, which are not reversible.
Yeah.
And even if they go away, their effect is intended to be induced by them. That effect is not going away. So it's
interesting because you have this market saying, okay, we want to go towards biostimulatory because we want to create collagen and create fat perhaps and grow. And you're saying, wait a second, I can get you a result with surgery that can get you more rejuvenated than perhaps the non-surgical route.
Yeah, I mean they're just different, right? So I think what people want to hear is I can do as much of column A as I want, and I will never have any consequences on my choices in column B.
Yeah.
But that's just not life, right? It would not be fair to say, having seen what we meaning surgeons around the world for the last 5 years have seen, many things in column A impact your ability to pick from column B. It's just not, and it shouldn't be a controversial statement. That's just, it's like saying more, I'm trying to think of a non-offensive analogy, but the more people you kiss, the less likely you are to get you have no additional chance of getting a cold.
The more donuts you eat, the more.
Yeah. So I mean, the more people you kiss, the more likely you're going to get a cold one day.
Right.
Like that's just it is. But kissing people's fun.
Okay, so what do you tell a 25-year-old says, I want my lips done, I want filler in my cheeks?
For the time being, I think I still like the HA class of fillers a lot, hyaluronic acid fillers, because they are reversible, and especially this 25-year-old demographic you just mentioned. It certainly wouldn't be a surgical demographic. I think that's perfectly appropriate, and those fillers actually don't really usually cause much trouble for anything surgical down the road anyway. I'm more worried about the real heavy, hot energy devices that you have to numb the tissues, put something under the skin. You heat it to a degree that partially melts the cheese, if you will. Those are the things that really worried me.
Yeah, and I don't want to say any brand names, but I know what you mean, because the radio frequency treatments and some of the ultrasound energy-based devices is probably what you're referring to.
So a 25-year-old going through something like that gives me more pause. They're trying to get a snatched jawline, and they're doing it by injuring their beautiful 25-year-old tissues. That gives me more pause.
Do you ever see people who get these treatments and they get fantastic results that are facelift-like? Oh, wow, you're good.
Well, yes.
Oh, thank you.
swap that out?
Not really.
Not
to be
really.
honest with you. People that have, so you can see nice results from these treatments, but in people that have like just the absolute right setup for it, they have a little bit of fluffy subcutaneous fat, well, they wouldn't be a facelift candidate anyway. So the people that are typically getting good results from them there are people we wouldn't do a facelift on in the first place.
Do you have a spa in your office that does fillers and toxins?
We do. Yeah, I've 7 injectors, and they do fillers and toxins, and they do Ulthera, which is an energy-based device. They do.
So you're offering these treatments at the same time you're saying, well, you know what, you got to be careful because too much of these treatments affect your surgical results.
Absolutely. Yeah, but these are discussions that we have
with the patients.
Yeah. So I think it's if you're going to a place that offers many of these different things, and surgery and information, and there's certain things we don't offer. There are other of these categories that we just don't. Again, I'm not going to mention brand names. We don't even do it because I don't feel like it's. I don't want to do that to a person. That makes any sense. So that doesn't mean we offer all of them, but we offer lots. It's also important to kind of draw a line. Like, so, people will often send me a message, like, is this treatment okay? Like it's always okay or it's always not okay.
Right.
Many of these treatments are okay in moderation, or okay for if you're trying to use it for skin quality, but they're not okay if you're trying to cook the skin to a degree that it's going to somehow shrink the skin. These are different, as you know, with biological tissues, certain degrees of injury speed up reactions or induce regeneration, and certain degrees of injury, sublethal injury, create a whole different response. So there's a gradient that, in the lower end of the gradient, things are generally safe. As you push it to the higher end of the gradient, things are less safe.
Right.
And I think in a practice that's broad scope, we're more willing to draw lines before you get to these higher ends of the gradient.
Tell me about some of the adjunctive treatments that you do to optimize your outcomes. TXA to reduce bleeding, tranexamic acid, hyperbaric oxygen to improve healing. Some people like arnica, exosomes. Are any of those things part of your routine to get better outcomes?
A lot of those things I think are, if not necessarily for better outcomes, maybe to try to decrease the recovery intensity.
Yeah.
So I've been using TXA in my patients since 2017. This is tranexamic acid. It's a clot stabilizer. It doesn't create clotting, but it helps when you're dissecting through tissues. You have little capillaries that are oozing. Big things you can cauterize, the little things kind of clot off on their own. Each of those clots needs to stay stable until the patient is healed so they don't start bleeding later on.
Right.
Minor bleeds create unnecessary bruising. Major bleeds create the trip back to the operating room in the middle of the night in a scary situation. Tranexamic acid helps decrease the chance that the clots that have formed either naturally or through cautery fail before the healing can take place. So we do use that. We've been using that for 7 years now. Hyperbaric oxygen we do use. I don't know that it makes a huge difference. I think you can start a fight on that one. We do use it on our post-op facelift patients. I personally don't think it's made a huge impact in less bruising, less swelling, faster recoveries. Again, it's a polarizing statement. There's some people I'm sure they're going to say it changed their life entirely. It's easy enough to offer. It's low risk. We offer it. We do manual lymphatic drainage. I think that makes a bigger difference. Manual lymphatic drainage is like a gentle massage that helps some of the swelling move along, kind of move towards areas with better lymphatic drainage. I think it's manually beneficial, and I think it's mentally beneficial. This is a 40-50 minute session of human touch and reassurance, and I think those things brings your cortisol levels down, helps the rubber band, some of the tension come off for a little bit during the healing process. So I think that's helpful both in a bunch of ways. But yeah, we do a lot of those things.
Tell me your favorite meeting of the year to present at or to be at. Where do you learn the most?
Currently, the last 5 years or so, I have gone to so many meetings, and there are almost no repeats. So they've been national and internet. It's not like I go to a certain meeting every year, every time. Yeah. So I don't have a
go-to.
I hate. I'm trying not to disappoint you, but I don't have like one where I'd be like, this is one I love, and I go to it like most years because I don't anymore. You know, I'm all over the map anymore.
All right, let's talk about social media. What's your thoughts on social media, good or bad for what we do for plastic surgery?
Overall good. I think it's overall good. I think if it's used properly, it's a good way for patients to be able to see who you are. And for, again, a lot of patients are picking you between you and someone else that's similarly qualified just based on who they think they're going to get along with. And it's an important thing. So I think they can see who you are, they can see what your results look like, they can see your approach is, they can see your personality. I use it a lot for education on the patient side. So I do a lot of the patient recovery journeys. I think that helps people see what they're going to see.
Most people don't do that, but you show that patient post-op day 1, 2, 3. I mean, you're really putting your results out there, you're very transparent. Yeah,
they're absolutely beaten up. If you go to my Instagram, the first highlight reel is complications, and you'll see one of my hematomas, an infection, a nerve injury, a seroma, skin irregularity, vascular compromise. You see all that stuff of my patients from me. So I think it helps them understand some of these things, really understand some of these things. I also use it for aftercare. So I'll often make videos of let's say taping or molding or massaging a nose, let's say post-op. I'll make videos of that. We'll teach them in the operating room, not in the operating room, in follow-up hours. And then we'll refer them back. We'll send a link to that video to their phone so they can watch it at home as much as they want to. So it serves a social media purpose, but it also serves an aftercare.
Do you like social media?
I love it, yeah. It's good and it's bad. I love it when the people that are actually interested and engaged and have the right reasons for being on it are interacting. It's great. As you know, people can be horrible. When the horrible people are interacting, well, then it's not so great. But on the balance, I think it's been a good thing.
All right, tell me a little bit about if you were not a plastic surgeon or doing what you're doing today, and weren't in medicine, what would you be doing?
We talked about this, teaching. I would absolutely be a teacher.
Teaching what?
Yeah. I would probably say, it's going to sound crazy, I'd probably say a high school science. If I was going to teach something, it'd probably be a high school science.
That's so funny.
Yeah. That's because all boys are 14 inside, so that's number one. And
that's a problem.
and then my family, like me and my son and my father, like we're built for the sciences. So I think you have an incredible writing flair too.
Yeah, I love to write.
But,
I would probably be a history professor if I had freedom.
Yeah.
And were your best friends from high school? What do you still keep in touch with them?
Yeah.
And what do they think of you now?
Nothing different.
Nothing different.
Yeah.
Same Mike Nayak that was in high school.
Yeah. Nothing. At least I don't think so. I haven't asked him directly, but I would say nothing different. You're different with your friends than you are,
Of course.
Yeah.
I think we all have multiple personalities with your family, with your friends, with your community, with your international. I think we all have different facets to ourselves.
Yeah, for sure.
All right, what's your passion?
These are the questions I have a really hard time with.
That's okay. Having a sip of beer makes it easier. Okay, I have to wait. If you were waking up on a Saturday morning, you had all the money and time in the world, what would you do?
So I love to cook.
Really?
So yeah, love to cook.
Pizza?
So you do too?
No, I hate cooking.
I said me too.
But I was going to say pizza?
I'm all right with pizza, but I love to cook. So that, I often say, I was on vacation once, and there was a guy at a pier cutting up conch, like the shellfish.
Fish.
Making conch salad. We called it fish salad. It was conch salad. Cutting up tomatoes, onions, peppers, lime, conch, selling little bowls of conch salad at the end of the pier. I said, when I retire, that's what I'm going to do. I'm going to sit there, cut the stuff up, make people happy, go home at the end of the day, be done. Like that's my passion, but I do love to cook, so I'd say maybe that's what I would do. If I had a kind of a hobby job, that would be it.
And where do the Nayaks retire to?
I had to ask
Would it be back to Effingham, or would it be to the Greek islands?
We had to ask the woman in charge.
It's always like that, isn't it? When 15 years from now, when people look back and they're going to say, God, I trained with Mike Nayak, or I learned from Mike Nayak, how do you want people in this field to remember you?
So, as I said, I didn't come up with any of the things that I do, right? So
Yeah.
100% of the things that I do now that I think give me reproducible results, make people happy, keep people safe, hopefully put me at the top of my field, I learn from other people, and I credit them as often as I can with every little step. You've probably seen me in lectures or in teaching videos or whatever, all the time. I've also had the great benefit, as I said, of knowing many of whom I consider the best plastic surgeons in our generation, whether it's rhinoplasty or aging face or oculoplastics. Final related blessing that I've had is I've had the ability to bring them all together, and so if I would like them to look back in 15 or 20 years and say, one impact that I've had has been at this moment where it is so possible to unite people and so possible to create interdisciplinary, intercontinental cooperation as a means of exponentially increasing the level of education and level of service for our patients. I would like to feel like I helped play some part of that.
You help elevate the whole field.
Yeah. Just in that sense of learning, teaching, uniting, I think it's been
There's no doubt in my mind when 20, 30, 40 years from now, when the residents look back and they're going to say, who are the surgeons who changed the way facelifts are done? Your name's certainly going to be up there with all those.
No, thank you.
Yeah. All right. Thanks so much. I know you got to go. I appreciate you being here. No, this was fun. I appreciate it.
Thank you.
Thanks, man.